What makes Planmeca's ultra low dose different?
Well, it seems like the industry for the past few years has talked about low dose over and over and over. And I think dentists need to be informed of what that means. So when a manufacturer lowers the dose to the patient, that's the easy thing to do. Maintaining image quality is the hard part, and that's what Planmeca does so well. So when a scan is taken, it travels around the patient's head, and when we want to do low dose, the manufacturer spins around the patient's head faster. They're called quick scans, and they take about 2 or 4 seconds to scan around the patient. They take about 400 frames during a 3D scan, but when they travel that fast, they can only take about half of those frames. Planmeca is different with Planmeca Ultra Low Dose because we don't sacrifice the amount of frames we take. So the studies have proven that low dose protocols by other manufacturers have a significant loss in image quality, and they're really not diagnostic and really used in practice. With Planmeca's ultra low dose, we have the ability to successfully reduce the radiation by 80%, and it's been clinically proven that we've achieved that without a loss of image quality. So it's a huge breakthrough, and it can really change how doctors use the machines.
So now that we know that you can achieve excellent image quality and low dose with Planmeca's 3D imaging, how do you think this affects clinicians' protocols when it comes to imaging?
Well, I think this has a huge impact on how they take their images, because today most look at 3D as a tool for a specific procedure. So they want it to place implants. They want it because they're going to do endo. Well, there's so much more to 3D because now we've successfully lowered the radiation levels to be less than a digital intraoral sensor. So now doctors can take them from the start and change how they diagnose from the start. So it's really, really great for the clinicians as well as for the patient because it's less dose. So today a patient comes into an office and they have pain or they have symptoms. Doctors are instructed to take a 2D intraoral digital sensor image. Study after study, research after research has proven that they're not very effective. In fact, they're probably about 25% accuracy for a periapical lesion. So now that we've lowered the dose to the patient that's less than intraoral, we suggest why not just take a 3D image from the start. We can improve patient care, we can increase our diagnostic capability, and we can positively affect treatment outcome. So it's a win-win for everyone, and we can do it all with lower dose. And I think we can change the gold standard from intraoral to 3D only with Planmeca.
Thank you so much, Brent.